treatment. So tonight at this webinar, we are actually coming at you from the West Coast. We are in Carlsbad, California at the Greenbrook location here. Here is our lovely receptionist, Olivia. But tonight we're going to be talking about what does the TMS and Spravato look like in a patient's daily life. And just to give you a little bit more information about Greenbrook, so Greenbrook has over 95 locations across the United States from the east to the west. They have treated over 57,000 patients, and they have over 10 plus years of experience. And in addition to that, they have performed over 1.9 million treatments. Now, tonight we're going to meet two people who have contributed to those numbers and have been able to help patients across the United States. But before we get into that, I'd like to ask you a question. So we're going to launch a poll. Who do you think your patient sees the most at Greenbrook during their treatment experience? Consult coordinator, treating provider, behavioral health technician, or are you unsure? I'll give you a few seconds to answer those. All right, well, tonight, one of the first people you're going to meet is a behavioral health technician at the Carlsbad location in California. Oh, and here he is.
Hi, everybody. I'm Sam. I'm one of the behavioral health technicians with Greenbrook TMS. I'm also the face that our patients see the most. And I can show you all a little bit about our office today, if y'all would like to join me on a quick little tour.
Sure, come on.
So in this hallway, we have all of our Spravato rooms. They're all singles. They all have one lounge chair. So our patients never have to worry about sharing a room with another person.
That's a beautiful space.
Yeah, it's huge. And then over here, we have two TMS rooms. So that way we can accommodate as many patients on our schedule as possible.
Amazing.
Here's another little lounge area where patients can wait if they choose. You can go and take a seat right here.
Oh, sure, thank you. So, Sam, tell me a little bit more about your role as a behavioral health technician.
Yeah, so again, I'm the person that spends pretty much every single treatment with the patient. My job is to make sure that they feel comfortable, educated, and reassured. I try to meet them where they are at the point in their lives, and really try to understand them as a person, any fears or concerns they can have regarding TMS that's preventing them from fully committing to it, and just walking them through every single day, step by step, trying to really personalize the experience to them so that way, they can commit to completing all 36 treatments.
Amazing. And so how do you and the TMS provider work together collaborating with the TMS treatment?
So I work with him in performing the cortical mapping and determining the patient's treatment location, but I can actually bring him out so that way he can talk about it a little bit more.
Yeah, no, that would be great.
Dr. Sargent.
So Dr. Sargent joined Greenbrook in 2024. Dr. Sargent, can you tell us a little bit more about yourself?
Hi, everybody. My name is Paul Sargent. I'm a psychiatrist. I've been a physician for over 20 years, served in the military for 25 years, and I joined Greenbrook really because I wanted to start employing more of these advanced procedures in my practice. And I've known Greenbrook providers who worked here longer than I have, and I really wanted to work with an organization that was experienced, well-trained, and had the framework and infrastructure to be able to deliver all the care that needed to happen. So this was really a good opportunity for me to develop more of this kind of experience and exposure with this type of treatment. I've been doing TMS in the military since about 2018. Prior to that, but really trying to scale that in a way where it was being used more consistently and more readily, and improving access to care for my patients who have treatment-resistant depression.
That's great. And so what would you say the typical Greenbrook treatment process is at your facility in Carlsbad?
Yeah, so the process is that we will start with an individualized assessment. I'll meet with patients online initially at first, or they may come into the office. And we're really trying to take a full history to understand exactly what psychiatric treatments they've had, what symptom course they've had, what's worked, what hasn't worked, and then make sure that there are no contraindications that could get in the way of safety for the patient. Then after that initial pre-assessment, we'll go through the insurance authorization process, and then we'll really bring them in for the start of treatment. And so on day one, what we do is we'll sit them down, and if they're going to start with TMS, for example,
We'll sit them down in the TMS chair. I'll explain the process to them. Again, answer any questions that people have because they can be unsure at first about what to expect. And then we'll go through a mapping process. And the mapping process is an individualized process by which I'm able to take the coil and using markers on their scalp, localize it to the spot that we feel is going to be optimal for getting their treatment, and also finding the exact right intensity that's going to get them the treatment response with the lowest possible dose of intensity that we can get. So it really is an individualized treatment plan. Sure.
Now, I would like to ask the audience a poll question. What do you think are the most common barriers that prevent patients from completing a treatment? Now, your answers are financial coverage, lack of knowledge on treatments, treatment candidacy, or you're unsure. I'll give you a few seconds to answer that. Now, Dr. Sargent and Sam, how does Greenbrook help patients kind of go past those treatment barriers?
Yeah, one of the things that we see first, and even kind of going back to the previous slide, is helping people to understand the process and deal with any issues that come up. So we start with them at the initial treatment to individualize it, explain it. But even mid-treatment, if they're having questions, concerns, I'll meet with them again. Even something as simple as getting a different haircut might change how the coil is going to fit. And so as we get people approved for the process, we'll oftentimes get a remapping code also approved by the insurance, so I can come through and readjust things as needed. Again, answer any questions at the midpoint, and then close to the end as well. Make sure they've gone into remission or had a good response. If there are any other symptoms that haven't gotten better, we certainly want to start talking about those and helping them understand what the next steps are, even with the referring provider, to help get that treated. So the number one barrier I'd say is really understanding for patients. That we really deal with that through education, explaining, answering questions, and engaging in a dialogue, so they know that this isn't a one-size-fits-all thing. That if they have any questions or concerns, they're going to get answers to that, and we're going to try to accommodate them. I'd say the other barrier that people have past their understanding is just the logistics. It can be a lot to ask somebody to come in every single day, 5 days a week for 36 treatments. What I want to talk to them about is how do we make that as efficient as possible. Once they've gone through the mapping phase, from the time they hit the front door to the time they come in, and Sam gets them set up in the chair and treats them and gets them back out to their day, it's usually about 30 minutes. We're very focused on efficiency because we want people to work this into their daily schedule. It can be a lot to ask, but again, once people start to feel better, that barrier starts to come down as well. The insurance coverage, I think we talked about that a little bit. We do have coordinators on staff who are really specialized in getting the insurance approvals done, and also communicating with patients about any copays or things that they like to pay, so that they come in with a clear eye. You don't really want people to be surprised halfway through treatment getting a bill they weren't expecting. So, and then really beyond that, it's about building motivation and maintaining that commitment. I think that one of the things I see here that I wasn't expecting, that I've really been impressed by, is just the relationship that the technicians build with the patients, the bond. It's not only just that the bond is helpful, but the technicians know to build that bond, right? Because it allows the patient then to have trust, to open up, to talk about things that maybe are concerning them. And the bond with the technician keeps the patients motivated through treatment to get through completion. That's one of the most important factors with TMS that you really want to do get through full completion. So I don't know if Sam, you want to talk about kind of what you do with patients to overcome those barriers.
Well, I would first off 100% agree that I think the lack of understanding is probably the biggest barrier that prevents patients from fully completing the treatment course. So my responsibility from the get-go is to just set the tone of what to expect. And one of my responsibilities as well during the cortical mapping is to collect some baseline information, like how much caffeine does this patient consume on a daily basis? What's their psychiatric med intake? Do they have any alcohol habits, or how much alcohol do they consume on a weekly basis? And I express to them, because I personally think for TMS, there's ways to boost the efficacy of it, and there's ways to do it right. And I want my patients to understand that if you're going to commit to something that's as demanding as TMS, there are ways to do it right. So I remind them the importance of consistency of like caffeine intake, psychiatric medication intake, and then also just in general, abstaining from alcohol 24 hours prior to your treatment, just because we're trying to maximize our safety precautions here at Greenbrook. Because this is, I inform them, again, looking for any opportunity to kind of educate them as to why these factors are important and why they should keep them consistent, is because they're all stimulants, they're all sedatives, they're all contributing to their brain's unique power level. So if they're keeping them consistent, they're always being treated at the appropriate power level that we get during the mapping. That's how they can kind of reassure themselves that they're always getting something out of their daily treatment because they're doing what they need to do correctly. But another thing I find that kind of gets in the way of the barriers, and which is like really important in terms of me establishing this level of trust with patients, is logistical stuff. Like a lot of patients are just like, oh, I have to find time in my schedule, like 20 minutes to come here. So that's why I think it's really important to, like, one, make sure, like, unlike most medical offices, that we don't have any wait time here. As soon as patients ring that doorbell, I'm there within seconds. The chair is already ready to go for them. I just get them in the chair and then I get them set up. So in terms of them having to set aside a lot of time in order to actually accommodate these daily appointments, I try my best to be as mindful about that. But other than that, I think it's really important to just make sure that the patient always feels that they can reach out to me if they need to, because timing is a big thing. And I want my patients to know that they can call me at any point, they can email me at any point. I'm always by the center phone. And if they ever need to come in at a different time, I'll do my best to accommodate that. And I think that's one thing patients really appreciate, because they ultimately want to do this. I know they want to. It's hard, and I'm trying to make it as easy as possible for them.
Well, it sounds like you guys have a very collaborative and compassionate staff here, just listening to you guys speak about it. Now, you keep mentioning mapping.
Yeah.
Let's go see the chair.
Yeah,
Let's show the audience what that is. Sam, you lead the way.
I have a few.
Yeah, so we have two. We typically try to accommodate as many patients as we can. We typically also have 2 technicians on staff, so that way we can have 2 chairs going at once. But this is the treatment chair. We already have it all set up with, earplugs for the patient, a cap if we were going to perform a mapping, and all these sanitation wipes that we change out and we disinfect the chair after every single patient.
Now, I know on our last webinar, we did briefly overview what NeuroStar TMS is, but Dr. Sargent, can you kind of give us a bit more information, just maybe if they weren't able to attend the last webinar?
Yeah, no, I'll make you a deal. If you'll take a seat in the chair, I'll start to show people
Sure.
how this looks a little bit.
Oh, this is comfortable.
NeuroStar Advanced Therapy is by prescription only. This demonstration is for training purposes only and not representative of an actual prescription MT. Patient prescriptions, outcomes, and experiences will vary. The most common side effects include temporary pain or discomfort at the treatment location and/or headache. There is a rare risk of seizure, less than 0.01% per patient. Please refer to neurostar.com for full indications, contraindications, and important safety information.
So, just to spare Kelly, a little bit of discomfort, we're not going to actually do any mapping or any actual stimulation, but I kind of want to show you guys how the apparatus works. You have this chair here, which is really adjustable and customizable for patient comfort and positioning so that we can get the coil exactly where it needs to be. And they're going to be sitting here for 20 minutes. You want somebody to be comfortable, not squirming around or anything like that. And then behind the chair, you have the TMS apparatus itself. Now, there's a lot of electronics here, but really where the rubber meets the road, the functional part of this really is the coil. Yeah, if we can go ahead and lean her back a little bit.
This is a very comfortable
Which
chair.
is what's called a figure-8 coil. And so really this is about the size of kind of a large grapefruit. It's got some knobs and some settings on it, a little lock button that you hear clicking and unclicking. If I was to do a mapping on Kelly, what I'd be doing is adjusting this with the cap on and bringing it over to the position on her scalp indicated for maximal stimulation. And then from there, what I'm going to do is I'm going to adjust that forward and backward, up and down, to really isolate the exact right spot that we think is going to get us over the left dorsolateral prefrontal cortex. And then I'm also going to start adjusting the intensity so that we can, again, try to dose this properly so she's getting the benefit without overstimulating her at the same time. Once I've done that, and I feel like I have this in the right spot, I'll set the chair up. And there's a few things you may or may not be able to see, but there's an AP bar and a few different adjustments back here. I'll set that up. We'll note exactly the locations of these things,
so that the technician can come behind me and consistently get the coil over the right spot time after time after time. Again, if midpoint something's doesn't seem like it's quite right, or the patient needs to have it adjusted, we can come back and do a remapping. One of the things that people will notice is sometimes a little discomfort behind their left eye. That's a pretty common one, and we can fix that stuff just by changing the angle of how the coil is and then readjusting.
It's actually quite comfortable now. Just to restate, this is just a demonstration. We're not actually performing a treatment today, but just to confirm, Dr. Sargent, this is a completely non-invasive treatment, correct?
Yeah, absolutely. Well, what it is it's a magnetic stimulation of the brain. So it really is, well, it's affecting the left dorsolateral prefrontal cortex. When you actually start to see and look at the fMRI studies that go on, there are changes that are going on in different areas of the brain as well. So we start to think about the brain not just as a bunch of distinct locations, but really as a network. And so we're influencing the network through a magnetic coil, but it's affecting the network. Now the difference is it's, when you think about invasive or non-invasive, is that we're not causing effects all up and down the body. So I like being a prescriber. I use a lot of psychotropic medication, but you're going to be getting effects from psychotropic medications wherever they go through the bloodstream. This is really a focused treatment on the brain itself for an intervention, just using a magnetic coil on the brain.
And Sam, what would a patient typically expect through the subsequent treatments after this initial mapping?
Yeah, why don't you show them?
Yeah, my role as a tech is to understand the patient and how to meet them where they're at. I will always be logged into their profile before they're even here. I'll get them seated, I'll recline them back, I'll get the coil placed, and before I start the treatment, I'll always ask them the same questions. The first one being, have you had any food and water today?
Yes.
So that's actually not a required question, but again, just circling back to always looking for any opportunity to potentially make a lifestyle change that could contribute to boosting the efficacy of this treatment. But also it's definitely something I've noticed that a lot of patients who have treatment-resistant depression and are at different places in their life, eating food and drinking water aren't always a priority. So reminding them that if they do eat food and drink water before treatment, they could potentially make it a little bit more comfortable for them. And that alone is usually something I notice makes a huge difference in sort of the patient's energy levels. The next question I'll ask is, have you had any changes in your daily caffeine intake today?
No, I don't think so.
Okay. And then any changes in your psychiatric meds?
No.
Okay. So those are really important, just because if there perchance were any medication changes, I could let the doctor know, and then he could go ahead and approve an MT check, so that way I can always make sure that I'm treating the patient at the appropriate power level. And pretty much after that, I'll ask them how they're feeling today, how they would rate their mood and sleep, so we can just keep a general track of their progress throughout treatment, and I'll get the treatment started. And pretty much after that, we'll find something to watch or talk about for the 20 minutes that they're here.
So it's very interesting. So what other things could a patient experience throughout their course of treatment?
Yeah, we'll have Sam kind of sit you back up again so you're not locked in.
Okay.
But there's if we can get that slide pulled up so we can see the roadmap. It's a fairly detailed slide, and I think that it looks very specific and kind of gives days and timelines for results. But what we really see is that for that first week, it's a chance for the patient to get acclimated to stimulation. Sometimes you can get a little sense of a tapping on the scalp, and people will kind of feel that might be uncomfortable at first. What we do is we're actually starting at a lower energy intensity level and then dialing that up as the patient tolerates it. And after about the first week, they become acclimatized to it, and they're no longer really feeling much discomfort. It's something they're pretty useful. It may not be fun, but it's certainly not like a sense of discomfort, not scary. And the tech is doing everything they can to try to reduce that. Over the first 2 weeks, what you really see, the first symptoms that I see improve are really sleep and energy. Right?
Okay.
And it is interesting, and not something you might expect, but people who have chronic insomnia, which is a part of depression, will find that they're sleeping better. And they'll come back and they say, I am. And they'll ask, is that because I'm being stimulated, or because there's the magnets are doing something to my brain to make me sleep better? And it's a really good question, but we do see that effect. The second thing we see is a boost in energy. They have a little bit more pep in their step. We see, with treatment-resistant depression, neurovegetative symptoms are very common.
And seeing that little bit of energy boost is really motivating for patients, because they can see like something's changing, something's starting to work. Now, after the first 2 week phase, that third and that fourth week, we kind of enter this middle phase, And what we start to see is a little bit more clarity, a little better perspective. Things don't seem quite so dark. Things don't seem quite so overwhelming. I'm starting to get a sense of my problem being in perspective, starting to see that these may be things that I can start to address. Again, not just what's going on in the room, but what's going on in my life, which is even more important. Then you get into kind of the later phase where you're weeks 5 and 6, the energy's improved, the sleep is improved, the perspective's improved, and now we're starting to see some behavior changes. We're starting to see those behaviors that are going to sustain resilience even after treatment and really help this to be have some longevity and have some durability to it. Where people are getting back into hobbies that they were interested in, they're re-engaging relationships that they need to engage in. They might be getting outside more, getting more exercise. That's really what we're encouraging through the course of treatment as well, because they may come for the stimulation, but this isn't just a matter of a procedure. This is patient care. We want to take care of the whole patient. We want to give them an opportunity to have a good life. And this is just one of the entrees, one of the avenues that we can give them to get to that.
And it sounds like it's like helping a lot of different aspects of their life as well, based off of what you were saying. Now, I know you said 36 treatments.
Mm-hmm.
Are there any barriers that you see with that? Or do patients, maybe want to stop treatment, or do they have any like scheduling conflicts, or
Yeah.
Holidays are always a big one.
Life happens, right? And we see, people who come in with kids and the kid may be sick and they can't come in. We're going to work with people to try to be as flexible as we can with the schedule, right? We know that we want to try to, be consistent and follow through, but life happens. And so we have to work with people. We have to be a little bit flexible. Now, and I think Sam will talk about this a little bit. Sometimes we do see kind of a plateau effect where people may notice, like, I'm getting better. And then over the course of a month, we have ups and downs. That's part of it. But we really reinforce, we want you to get through all 36 treatments. The data is really there to say, this is most effective when you get the full 36 treatments. Yeah, and so you can see that when we look at both TMS and Spravato, if you just look broadly at the literature, you'll see remission rates of around 50%, maybe a little bit more for both of these procedures. But I'll tell you, if they don't get through all 36 treatments with TMS, they're not going to be as likely to get those good remission rates. And 50%, sometimes people say, oh, maybe it should be more, but you got to remember, this is a population of people who've struggled and not really gotten benefit from other treatments. This is a historically difficult to treat population. So getting that level of response and remission really is impressive.
Yeah, definitely. It sounds like completion is key.
It is.
Now, Sam, how does that affect your role? Like, what are some of the ways that you kind of, encourage the patients to continue to come to their treatment?
So I really just look for any opportunity to reinforce the positives, because I understand that a lot of my patients are in different places in their life, and sometimes we can't have consistent 5 days in a row of attendance. I just remind patients things that they can do outside of treatment to boost the efficacy, like pairing this with exercise, pairing this with outdoors time, just anything that could potentially make this a little bit more effective for them. But also, outside of this, patient care wise, they're taking care of themselves. But also, when patients feel really discouraged, like about the plateau, for example, I actually like to use it to our advantage, because typically that plateau is a product, because again, circling back to like viewing myself as kind of like a coach / advocate for patients going through TMS. And I view this 36 treatments as kind of like a training program that you can do right and you can do the best way possible. And I like to remind them that, if you're adhering to a training program, and this is quite like exercise for your brain, it's very normal for you to feel fatigued. It's very normal for your brain to experience a soreness that presents itself as like maybe a dip in symptoms. And I like to remind my patients that that doesn't mean that TMS isn't working for you. It means that your brain is responding to the treatment, and it's sort of, in simpler terms, learning what to do with all of this influx of new activity to a region of the brain that has historically lacked it. And those are just some of the ways I like to communicate to patients about, the hard parts of TMS.
This sounds like a very effective treatment for treatment-resistant depression.
I would definitely say so.
Now, I know you also offer another treatment, and this is going to launch us into our next poll. We have one more thing we want to talk about with NeuroStar, and that would be, but I'm going to ask the audience first, is based on real world evidence, how long can NeuroStar TMS remain effective for patients? What do you think? So 3 months, 6 months, or 12 months, or you're unsure? All right, so Dr. Sargent, what is the durability of TMS?
Yeah, that's the perfect next question, because you start with, is it effective? Does it work? Right. And so for those of us who work in mental health, and we're seeing patients a lot, and they've tried so many things, and they start to kind of lose hope. Will it work? And they come in here and you start to see, like, yeah, it'll work. But then, is it durable? Does it last? Really, somebody can come in and get 36 treatments and then they're good for a period of time. Like, there's no maintenance cycle for this. And the answer is no. It's FDA approved for 36 treatments. And when you actually look at the data, there is good durability. So the slide you see in front of you is a smaller study, but at least in this one, you were seeing 62% of folks achieve remission of symptoms at the outset. When you go out 6 months, that remission rate is consistent. When you go out 12 months, that remission rate remains consistent. So again, I think it's about this is an important way to kind of break people loose and to get them back into a good quality of life. But they're oftentimes receiving concomitant treatment. They might remain in psychotherapy. They might remain on medications. But one of the questions I like to ask people right at the outset is, if you weren't feeling so depressed, what are some of the things that you would like to be able to do with your life? Mm-hmm. And as we go through treatment, I revisit that again, right? Like, okay, you've been through a few weeks. Remember when you told me you'd like to be getting into this or this or this? Why don't we start doing that? Mm-hmm.
That's a very good motivator. And it sounds like, I know we say 36 treatments, it could maybe sound daunting at first, but with lasting effects of potentially 12 months, that sounds like a really good benefit for treatment.
It does. And, without treatment, again, treatment-resistant depression, you'll see a recurrence rate of around 80% of people having recurrent episodes. So being able to get 12 months of relief is pretty impressive. If somebody then does have recurrent symptoms and they want to come back, we do have patients who come back and get a second round of treatment. We would fly back to the insurance company for approval, and commonly that can get approved. It's not uncommon at all if somebody does have recurrent symptoms that we can get them approved again through the insurance company.
Well, that's good to know that insurance can cover that as well. Now, this is actually where I was about to jump ahead to, but since we are talking about TMS, I know we have another treatment here at the facility. So this brings me into my next poll. It is a bit of a trick question, but why don't we go ahead and head into the other room? But I am going to ask the audience, what other treatment option does Greenbrook offer? We mentioned it earlier, so I'd like to see what they think.
You better get the answer right, because she already told you. Just saying.
So the answers were Spravato, TMS only, or unsure. Well, the answer is Spravato, and that is where we are now. We are in the Spravato room, correct?
That's correct.
Now, again, like we started with TMS, if you weren't able to join the last webinar, Dr. Sargent, can you just give us a little rundown? What is Spravato?
Yeah, so, again, here we are in another comfy chair room. If nothing else, Greenbrook is full of comfy chairs, so you can send people over for that. Spravato is a ketamine derivative, S-ketamine, and by now it's been out on the market for so long. People are talking about it enough. I think people have become pretty comfortable with this medication, but it's an enantiomer of the ketamine molecule that's an NMDA receptor antagonist. And this has been FDA approved again for treatment-resistant depression. So when people come in, instead of coming in for 36 straight treatments, now what we're doing is a process where they might start out at twice a week for an induction phase, and then gradually kind of spacing that out, but then they will have maintenance on Spravato. It's a very different type of treatment. It can be a little bit dissociative. One of the key things to know about Spravato is that you really do need to plan for having a ride home, right? You can't drive yourself home after this. In fact, we tell people not to drive until after you've had a good night's sleep, because this can be a little bit dissociative, and we want to make sure that, again, safety is first. So again, I'll do a pre-assessment with somebody before we ever get this approved. I'll answer their questions. When they come in for the induction phase, again, I'll come back in, talk, answer any questions, clear anything up that we can. We get vital signs on people to make sure that they're in the right place, that this is safe for them each time that this is going to get administered. And then we kind of get into what we would call this induction phase. So the first dose we give people is 56 milligrams, which is 2 of these nasal inhalers. That is kind of a test dose just to make sure that they tolerate it well. What we want to do is advance that quickly to the 84 milligram dose, because we've really seen that that's much more effective, and the data would bear that out as well in the randomized control trials. So the induction phase goes twice a week for 4 weeks. And then we start to step that down. We kind of get into this early maintenance phase, which is once a week,
weeks 5 through 8, and then after 9 plus, would be once a week, or maybe even space that out farther. I have some patients, although it's not the typical protocol, but I have one gal who comes in once a month, and that's enough for her. So that's a typical course of care. Sometimes patients will feel like they need a little more time at twice a week. I've stepped them down to once a week, and they're feeling like they're not quite ready for that. Again, we'll fly back to the insurance company. We've been successful getting approval for them to remain on twice a week for a little bit longer until we can then kind of step them down. But again, the goal here, just like with TMS, is we want to give people the best possible results we can with the least possible interference in their life. These medications are helpful and for some people life-saving, but we don't want to overdo it with anything, right? There's a sweet spot that you want to hit with dosing, safety, and efficacy, and just doing a good job with patient care.
Sure. And do we have, can we show a demonstration possibly to the audience?
So this is just, it doesn't actually have any medication in it. It's just for training purposes. This is what one of the sprayers looks like. So as Dr. Sargent was saying, the 56 milligram kit would have 2 of these, each one being like 28 milligrams. And each little green dot represents 1 spray, so 1 for each nostril. I typically demonstrate to patients how to administer the device. I'll let them know that they want to sit exactly how Kelly is sitting, plug 1 nostril, insert the sprayer into the nostril that's not plugged up, and kind of like imagine they're aiming towards their opposite eye, because that can kind of prevent it from just shooting straight up the nasal canal and causing a little bit of a burning sensation. And then as they're spraying, I'll tell the patient to just inhale through their nose like they're smelling flowers, and then they'll do the exact same thing to the other nostril. I like to give the patient the opportunity to kind of play around with the training run, and then kind of, if you want to just click it in to see what it's like. Yeah, it's like it has to click. It has like a CO needs to break, and then there's one more. So if you want to click one more time. There you go. And then I'll take that back from you, and then.
Oh, and so that would click as if I were a patient, as if
Yeah. And then I would just reset it. And then assuming that is an actual sprayer.
This is a demonstration?
For demonstration purposes only. The patient would then, I would walk them through it verbally. You can insert it into whichever nostril you want to start with.
Not gonna, yep.
Okay. Plug your other nostril. Imagine you're aiming towards your opposite eye.
So like this?
Yeah. And then spray and inhale like you're smelling flowers.
Oh, I think I did. Oh, no, that's okay. That one, works. So there's 1 green dot left. Okay.
Yeah, and then you would do the exact same thing with the other nostril.
Okay. So just.
Exactly.
Okay.
Yeah.
That's pretty simple.
And then before that, I would have checked the patient's blood pressure and blood pulse oximetry and make sure it's in acceptable range. I'll remind them that there's one more sprayer. It's their induction appointment. So I'll come back after 5 minutes, and then we'll do the exact same thing. I'll let them know that I'm going to set a 40-minute timer, and then there's a call button right here for the patient. If they press it, and I'm going to be sitting in a room where like I have a little monitor, and I'm able to see the patient via that camera up there. If they need anything at any point, they press that, and I can see which room was alerted. I'll just rush right over here, and I'll see what you need. There's also some Jolly Ranchers. We run out of these quite fast, actually, but Spravato does have an aftertaste, so patients tend to prefer that the most in terms of chasing that aftertaste. After the 40 minutes come up, I will come back, check your blood pressure again, check your blood pulse oximetry again, and we can kind of talk about what you experienced, how your appointment was, because at this point, the patient is coming down. And then once I'm done with that, I'll set another hour timer, and then I'll come back, and then I'll check vitals one more time. I'll talk about everything, and then I'll bring Dr. Sargent in because he will chat with patients at the end of every single one of their Spravato treatments.
Sounds like you guys are very accommodating to the patients as well. You have a comfortable chair, you have little things to eat while we're in here. It's amazing. So, Dr. Sargent, can you tell us a little bit more about the efficacy of Spravato?
Yeah, similarly, we see response and remission rates. The remission rates are typically over 50%, which you'll see on the slide. I will say anecdotally, with my experience, I've been doing this over 20 years as a physician. I have a number of patients who have tried 2, 3, 4, 5 antidepressants, augmenting with, second generation antipsychotics, just all sorts of different combinations, and still find that some people just aren't getting that breakthrough. Their PHQ-9 score is staying high. I've seen coming in here has been actually pretty impressive. I've seen patients with straight threes down their PHQ-9, and after treatment, there are really none. People who've been chronically suicidal every day, right? They habitually are thinking about suicidality. That's been their life for years, and now they're not having any suicidal thoughts. It's really interesting, really even more so than I would have expected before I started using Spravato as a treatment option for people. I've been very impressed.
I've actually had multiple patients tell me that Spravato was the first thing that really helped with their suicidal ideation. That alone is amazing.
Yeah, and believe me, I'm one of the bigger skeptics of the world. So, if I say it, I'm telling you the truth.
So what are the long-term effects of Spravato?
Yeah, so we know that, again, TRD, treatment-resistant depression, has a waxing and waning course. We understand that the nature of this condition is to have recurrences over time. Without treatment, up to 80%. What we see is that when people are on maintenance Spravato, the recurrence rate of their major depressive episode is going down. Plus, they're getting this constant engagement with a team. If they're coming in once a week, they have a chance to kind of check in with a technician or check in with a doctor on a regular basis to kind of go like, hey, it seems like things are not quite what they were. We can dive into that briefly and kind of say, what do you think might be going on? What can we do to make some adjustments on that? Or, hey, maybe it's time to work with your referring provider, your primary psychiatrist, your primary care doc on this or this or this as well. So we use these opportunities to have meaningful conversations about improving their health overall. And I think that when you can get to that recurrent episode early and start to deal with it, start to address it, the risk of that really becoming a full-blown major depressive episode goes down. So there's a lot that kind of goes into it beyond just the pharmacology of the medication itself, but how it's administered, how the team works to deliver that and interact with the patient to care for them.
So sometimes there's a lot of collaborative efforts within the office, but also outside the practice as well, especially if patients are referred into Greenbrook, which actually brings me into our next audience poll. So how much do you value consistent communication from Greenbrook during your patient's treatment that you have referred, or how much would you value that communication? I'll give you a few seconds to answer. Extremely valuable, somewhat valuable, not valuable, or maybe you're unsure. So it looks like everyone says extremely valuable. That's great. Now, Greenbrook does offer transparent communication. So with the sign release information, their team will provide multiple updates to the referring practice. And the main goal is to act as a collaborative partner. Now, Dr. Sargent, can you give us a little bit more information on how you as a provider interact with other practices?
Yeah, I mean, I recognize we're a part of a treatment team, but really, they have a treatment team that's referred them to us, and we want to collaborate with that team. This is the ongoing team is going to keep taking care of them, whether they're with us or not with us. I highly value the collaborative communication. I think that's one of the downsides of modern medicine is that unfortunately providers are often so isolated doing things we don't have a chance to reach out, touch base, just to give each other updates and talk. I personally very much value that, and if you have a patient who's being treated here, you want to reach out, you want to talk about that, by all means, I'm happy to do that. I'll give you my cell phone number. We can talk. I think Dr. Civic is out there in the audience, if I'm not mistaken. I hope you are. But I know that we've been able to talk about patients in the past. And I think it really leads to better outcomes when providers are collaborating. We're all on the same page. Patients are getting that team experience of their overall care. So, by all means, understand that if you refer, we want to partner with you. That's the goal.
Well, with that, I think it's about time to transition into our Q&A section. So do you want to go back into the office and get set up for that?
Okay, sounds good.
All right.
Camera coming on. Yes, I had to put glasses on. I'm an old man.
So we're here for the Q&A section. So go ahead. So if you'd like to submit a question, you can go ahead and submit that through the questions pane. We did have a few questions that were submitted through the registration process. So we're going to go ahead and kick it off with those. So, Dr. Sargent, let me ask, how long does it typically take for patients to get started after the initial referral? What does that time frame kind of look like?
Yeah, that kind of goes back to why I opted to start working with Greenbrook in particular. They have a team, they have coordinators. And so when people are being referred in, they should be getting a call back within 24 hours, a warm handoff, an engagement. We've got the message, we want to work with you. Then the coordinators will go aggressively kind of back and forth with the payers, the insurance process to get the verifications all done. But we want to keep the patients engaged and informed all the way through that process. So if your patients are referred over or feel like there's, again, a gap in communication, that is not the way we want to do business. That's not the way we want to partner. So please, by all means, voice that concern and we will make the change. We have the people, we have the staff to make that engagement. So 24 hours is where we really should be.
Oh, that's actually a very fast turnaround time. Now, next question that we had submitted was, what is the best way? We talked about this a little bit earlier. Where's the plateaus and another word I believe is used for it. What is the best way to get patients through the dips or plateaus during TMS?
Yeah, it comes down to trust. I think Sam talked about this, and I think he does an excellent job. And I think he's actually really done a really good job just during the webinar. You get kind of a chance to see a human being, right? And I think with the kind of interventional psychiatry or procedural psychiatry types of products, people get the sense that this is a cold process, this is sterile, they're just going in and hitting buttons, and they really don't talk to or engage or get to know the patients. But that's the farthest thing from the truth. We actually really do engage closely. We care about what's going on with the patient in their life. We do everything we can to try to accommodate.
Oh, that's awesome. Definitely great to accommodate patients and try to make sure they're getting the most out of the TMS treatment. Now, next question we have is, if patients are really thrown off by the time commitment when they have a busy schedule, how do you frame it to them? So Sam, I'm actually gonna pitch this one to you, and because you're one of the main people they see, and I'm sure you probably hear it maybe daily. How do you combat that?
Yeah, so depending on our current schedule, our schedule hours aren't always fixed. Like if my final patient ends at 3 p.m., for example, I have no issue opening up a 7 a.m. appointment slot every once in a while, as long as my manager permits it. But reminding patients that treatment is typically only 20 minutes long, and I know it is hard getting here, and it does take time, but I kind of also, without words, I do show patients that they're often quite surprised that when they ring the doorbell and then I'm out there within seconds of them being there, there's no actual wait time. They come in, they get their treatment, they're gone. So it's something that patients can pretty much easily accommodate on their commute home for work, or again, if I'm able to open up a 7 a.m. slot every once in a while, something that they can accommodate on their way to work. And it either sets the tone for their day or, sets the tone for their night. We try to be as accommodating as possible here.
Well, that's great. I know just sometimes, I just my own personal experience with doctors is trying to find when can I come in so many times during my own office hours. So it's so nice when the practice is able to accommodate those earlier hours or those later hours for a treatment or anything that may be. Now, next question we had submitted was what is the typical workflow of patients from consultation to starting TMS or Spravato?
Yeah, I think we've talked about that a little bit already, but they're going to come in and they're going to get from the initial phone call, they're going to work with a consultant, and the consultant becomes kind of a consistent person that they're interacting with through that administrative process, right? There's the nature of modern healthcare. You have an administrative process before you can get into the clinical process. The coordinator becomes, a consistent presence and person through that. So that's number one. And then that'll get handed over to the doctor to do a pre-assessment. Again, I'm taking a full history. I'm trying to understand how this fits into the context of their life. There are patients who aren't necessarily a good fit. And if that's the case, I'm going to say so, right? We're not just putting people in for the sake of, throwing more treatment or medication at them. I have to make sure that in my conscience, I feel like this is the right thing. This is something that's going to give them a good chance of symptomatic improvement with minimal side effects. And then from there you get into treatment, right? And so I begin that treatment process and do the mapping or start with the induction process. And then the technicians, right, really become kind of this consistent and engaging presence for them. So there's people. The work, there's a workflow, but I think there's a people flow all the way through this, which I think is even more important.
Now, that actually brings me into another question. So adolescents, I know recently TMS was cleared for adolescents ages 15 to 21. So working with adolescents in Greenbrook, how does that work with the parent-guardian relationship during that consultation process?
Yeah, surprisingly, I find teenagers are actually more flexible than a lot of other patients. So they are more accepting. They're less concerned. They don't they don't seem to get as bothered by the contraptions or the technology. And so they embrace it pretty well. It's welcome to have a parent with them. If a parent would rather sit out in the lounge, that's fine, but we want to engage both, right? Because one of the things that you do find with adolescents, while they're more accepting, they can also be more inconsistent, right? And just like I was, and just like you were when we were adolescents. And so involving the parents is a really important part for sustaining the motivation and building the consistency. And then the prioritization. I think sometimes teenagers can have a hard time figuring out, well, what is the priority? And, how do I balance out, my soccer practice with my need for TMS treatment or whatever it is, and trying to help them realign and reprioritize so that they know that this is for this period of time that you're with us, it really does have to be a priority. The good news is after we get you through treatment, you're going to be feeling better and you're going to be able to go back to those other priorities with a lot more vigor.
So transitioning back into actually TMS and Spravato questions. Now Spravato, it is only cleared for approved for adults. Now, is there any case where you might see a patient does both TMS and Spravato, or start the course of TMS and goes into that, or how do you determine this?
We generally speaking want to try a treatment and really see if that's going to work. If it doesn't work and they need to transition to something else, then we can have that dialogue at that point in time. Again, it's going to involve their insurance payer, and we have to go back and see if we can get approval for that. But if one of the things that I think is an important consideration in medicine in general is when something seems to be treatment resistant up front, you really have to reassess the diagnosis. Is the treatment not working because I don't exactly have the diagnosis on, and maybe that's not the right treatment for that diagnosis. So again, if we're doing this and it's not working, I want to sit down with the patient. I want to understand what else might be going on. Sam had talked about alcohol use before, and we have a policy. We don't treat people if they've been drinking the night before. But substance misuse is a very, very common problem in our society. We see things like cannabis dispensaries, and so we're seeing a lot more drug use in society. And so if somebody's not getting better, can I ask some questions about that? Can I understand what their patterns of substance use might be like? Could that be influencing the treatment? Can we get that out of the way for the course of treatment, so maybe we have a better chance of success?
There's definitely a lot of other things that people have access to nowadays.
For sure.
Now, that actually, I think you mentioned this before, but really quick, if anyone would like to submit a question, you can use the questions pane. If you're in the live event, you can also ask one of your regional account managers to submit a question for you on their behalf. So another question we just had submitted was, I think we briefly touched on this, but how do you typically determine how long someone should be on maintenance for Spravato?
Yeah, there's no clear answer really. When they come in and they're benefiting from it and they feel like this is something that's useful to them in their life, then I want to try to continue that for them. I want to space that out to the degree that we're able to. But if somebody comes in and they say like, you know what, I'm doing this once a week and my life is better. We tried to space it out to once every other week, and I'm noticing that I'm having less energy. I'm feeling more sad. I'm feeling more bummed out. Again, I want to try to bring it back to the treatment frequency that fits for them. So I don't think anybody loves the idea of telling somebody right off the bat like you're going to be on lifelong medication. That's not the goal. But we're really going to be following people over time, and if we can get to some symptomatic remission and maintain that by spacing that out farther and farther and farther, it's really what we want to do. And again, I think it gets back into that comorbid, concomitant kind of factors. If somebody comes in and they're going through bereavement, they've lost a loved one, that's going to influence the treatment, right? You cannot separate the biology from the psychology and from the social experiences of their life. If they're going through a divorce, if they've been laid off from a job, these are important factors, right? That are going to influence how they feel. Now, does that mean the treatment is less effective because they're having, some ongoing sadness after an episode of bereavement? The answer is no. It's a good treatment. It's an effective treatment. If they were going through that period of bereavement without the medication or without the TMS, I really wonder, it might even be worse for them. So again, when you see good results, you're happy. When you feel like there's something still that needs to be worked on, pay attention, right? You want to get into that and really understand and talk about what other treatment options might be available to them. But again, if we're not going to offer that here, I'd refer them back to their treating provider to say, you might want to have a conversation with your provider about this or this or this and see what their thoughts are, just so that there's a door open. They may not have known that there might have been, something else to consider too.
Now, shifting back into CMS, that actually made me think of another question. As you might have briefly mentioned this, but if a patient comes in, they are on a few different medications.
Mm-hmm.
Now, it's starting TMS. Would they stay on those medications?
Yeah, typically.
Typically?
Mm-hmm.
Okay. And then if anything changes, do you work with the referring provider and kind of communicate back and forth? How does that work?
Yeah, what I'd like to have happen is them to stay on a consistent regimen through the course of TMS if we can. Sometimes that's not always possible. And so, like Sam had already mentioned, kind of when we were standing next to the TMS machine, if there's a medication change, that's an opportunity for us to go redo the motor threshold and really make sure that we have the parameters dialed in for what's going on with them. So yeah, it's a very adjustable and flexible process. Again, there's a protocol, but there are people going through a protocol, right? And so we're here to treat people, and that's the priority is to. Yeah.
Now for TMS treatment, I know for Spravato, you monitor the patient from outside. For TMS, is that similar, or how does that work? What is your relationship with the patient through TMS versus Spravato?
Yeah, so Spravato is more so like it's independent for the patient. Like patient gets to sit in their own private room and kind of do whatever they want to do with Spravato. For TMS, I'm sitting next to the patient the entire time because it's just we're always making, for the nature of TMS, you have to make sure the coil is always making contact in order for the actual dosage to be received by the patient. And fortunately, those machines will just automatically pause if it ever loses contact. So then I know, okay, I need to put a little bit more pressure. But yeah, I'm there logistically for safety, just to make sure that the patient is safe. But it also is an opportunity to kind of like talk the patient through. Spravato is one of those things that's better to experience independently, away from people. Whereas TMS is definitely better if you have somebody in your corner, kind of like encouraging you through the process, checking in to see if you're comfortable. I always, because I feel like one of the biggest factors that contributes to patients in TMS not wanting to do it anymore is being uncomfortable. And when I ever bring up like I can tell like if their face is squinting or if their eyes are squinting or if their eye is watering, I'm like, hey, are you okay? And then most patients will be like, yeah, I'm fine, like just trying to get through it. But then I'll let the patients know, I can make comfort adjustments to make it a little bit more comfortable if you're experiencing X, Y, and Z. And then the patients some will be like, okay, but then there's still that few that like are a little bit like they just want it to not change. They think that any adjustments I can make could potentially impact the efficacy of the treatment. But I like to reassure patients, and this is why I believe personally, again, talking y'all's ear off, knowledge equals reassurance. Understanding why we have these adjustments we can make to address discomfort, like pain behind the eye. And correct me if I'm wrong, Dr. Sargent, but I typically will inform patients that sometimes when the coil is placed, and I like to like stand in front of them and like demonstrate on the left dorsolateral prefrontal cortex, which is about the size of a golf ball. And then I think y'all saw the coil, it's pretty large. That it sometimes makes contact and stimulates that trigeminal nerve, which is what really causes that discomfort behind the eye. The trigeminal nerve kind of like runs around and behind the prefrontal cortex. So by making like coil angle adjustments, we can stay on that golf ball, but just avoid stimulating that thing that's causing the discomfort. And I love, one of my favorite parts about this job is when I make a coil angle adjustment and a patient is just like, you can tell they're so annoyed by how uncomfortable it is at first for them. And then all of a sudden their eyes light up, they're like, that's so much better. Like then they're like, I can actually sit through this for 20 minutes at a time.
Yeah, and it's funny, be right, because again, sort of like when the doctor's in the room and I'm adjusting things, they'll be like, no, I'm fine,
Yeah.
But then they'll open up to the tech, right? And they'll say like, actually, I'm not quite as comfortable as I told Dr. Sargent. It's great. We want them to have that relationship.
Now, in what cases for TMS treatment would a patient ever need to be maybe remapped during treatment?
Mm-hmm.
Does that ever happen?
Oh yeah, no, yeah, and I think we talked about that a little bit. It could be for a variety of different reasons. As much as silly as it sounds, getting a different haircut. I mean, you can see Sam, right? Imagine if that guy came in, with his head shaved one day, we'd have to remap, right? Because the placement might be a little bit different. And so that's usually a part of the approval process when we apply to the insurance payers right up front. There's a special code for remapping, and that's on the request, and then that gets approved. So it's usually not a big deal at all.
We have about 2 minutes left. We did get a question in from Jacqueline. Jacqueline's question is, does Spravato and or TMS work best for patients who tend toward more anxious or more dissociative personality types?
Yeah, that's a really good question. So TMS has been really approved for this anxious depression. You see that quite a bit. With the dissociative personality types, a lot of times there's a lot that goes into that, right? And when somebody has dissociation patterns, there may be some history of trauma in their past. In fact, we know that that's oftentimes associated with PTSD, and we sometimes see that major depressive disorder associated with PTSD and trauma. And so when you have that trauma background, again, while TMS is more kind of been researched and studied and improved for this anxious depression, the truth is, when I see people with a trauma background, they don't tolerate discomfort quite as well. The noise of discomfort can be unsettling for them. And so I am, again, finding people with pretty stark abuse backgrounds, childhood trauma and things like that kind of got this depressive episode going. And I'm seeing them do well with Spravato, actually. Again, the classic picture of the person who may have had some pretty serious abuse as a young person. They become kind of self-blaming. This chronic suicidality kind of develops, and I've seen that type of person do phenomenally well with Spravato. It gives them relief. So I hope that answers the question. But I think either is a good option. But again, it's going to be kind of patient specific, and surprisingly, as much as we usually want to kind of target treatments towards symptoms or conditions, sometimes in this case we're looking as much at logistics as anything else. The person may say like, I can't not drive. I have to be able to drive to do this or this. And it's like, well, we're going to probably move you towards TMS.
So I know we are at time, but we did get one additional question in from Aaron. And I just want to make sure we can capture it. So if a client has already done ketamine treatment or Spravato elsewhere without much change, is TMS treatment likely to be effective? So similar to the question we asked earlier, but maybe vice versa.
Yeah, I think that's a really good question. They've tried ketamine in the past. They really didn't have any benefit. You might actually be surprised if they've tried ketamine and not gotten a benefit, they still might get the benefit from Spravato. I've seen that quite a bit as well, where somebody was kind of like, I didn't like the ketamine, and they were a little hesitant. But again, the ketamine is not necessarily FDA approved for these conditions. S-ketamine, this enantiomer ketamine, is FDA approved. It's been researched and studied and approved to treat. So I would tell somebody if I could get them through that initial fear or doubt based on their previous experience, I think they could do really well with either treatment.
I thank you guys so much for giving us all this information on TMS and Spravato. Sounds like both are very effective treatments here at Greenbrook.
Yeah.
Now, I do have one last audience poll for everyone before we close out the evening. Now, do you think that you have patients in your practice that could be candidates for the Greenbrook treatments? So yes, no, or unsure. I'll give you a few seconds to answer that.
So it seems like we have a lot of yeses, so that's very exciting. So the next piece I'll show you how if you would like to refer a patient to Greenbrook, on this next slide you'll be able to scan the QR code to help you get started. So it'll take you to the Greenbrook website. You can complete the referral form, and that will be sent and will be coordinated. We'll coordinate with you throughout that patient's treatment if they come in for treatment, and we'll keep you updated. But that would be how you're able to submit a patient for referral to a Greenbrook location near you. And we'll leave that QR code up just a little bit. So if you'd like to scan that and just make sure that you're able to access it, especially if you're at the in-person live events. And with that, we'd like to thank you guys so much for joining us this evening and taking the time out to hear about the treatments that Greenbrook offers. Thank you so much to Sam and Dr. Sargent for your time tonight. You guys were amazing. You just gave us so much really great knowledge about these treatments that can help a lot of patients. So again, thank you to the audience for being able to join us. You'll see here just some indication, safety information as well that we'll play through the rest. But I hope you have an amazing evening, and we'll have another one coming up soon. So have a great night, everyone.
Thank you, everybody.
Thank you.